of Västra Götaland, Uddevalla, Sweden. I'm so grateful that I'm able to present our study that we just recently published about 1 or 2 months ago in the National Journal of Emergency Medicine. And we were talking about urological emergencies in 2019. It's a retrospective evaluation of epidemiology and management in a Scandinavian tertiary setting. And when I was asking ChatGPT, what does a Bosnian urologist look like when he's supposed to present at BHAAAS? This is the picture that they came up with. And I think it's quite accurate. Maybe I don't have as many gray hairs yet, but we'll see in the future congresses. Maybe I'll start looking a bit more like this. So what is actually the new hospital group or the region of Västra Götaland? Well, it consists of this area that is encompassed on the left part of the map, with Gothenburg being the epicenter with Sahlgrenska Academy. And then our hospital is responsible for the green marked area, which is divided in 2 hospitals, but belonging to the same hospital group, which is Trollhättan and Uddevalla. And we have approximately 300,000 patients that live in this area. And during summer, we get an additional 100,000 patients from the rest of Sweden that usually visit the coastline. At these 2 hospitals, we do about 19,000 operations each year, of which approximately 5,000 are emergency operations. So what was the objective of our study? Well, it was to develop a baseline database detailing the distribution of urological emergencies and to define their epidemiological profile in a tertiary care setting with the hope of providing important data for health planning. The study design, well, it's a retrospective study, which was conducted on all of the patients that visited the emergency department of the new hospital group. And medical records of the identified patients were reviewed retrospectively to summarize pertinent information. And so what did we define as urological emergencies? Well, obstructive uropathy, such as renal colic, acute urinary retention, catheter-related issues, microscopic hematuria, scrotal and penile emergencies, postoperative complication, trauma, urinary and genital infections. And it's good to note that at least at our hospital, but also in Sweden, we regard as urinary tract infections in men as urological diagnosis, while in female, they are often treated as part of internal medicine or infectious diseases. So what was the results of the study? Well, we looked from January to December of 2019. There was a total of 70,765 patients who visited the emergency department, of which approximately 3.5% presented with 1 or more urological complaints. 71% were male, and the overall median age was about 64 years old, with seeing in the female group, it was approximately, the median age was 55 years, and within male, it was 67, but an overall median age of 64 years. A total of the 2018 patients of the 2035 were self-referred to the emergency department, and only 3 were referred by a general practitioner. So of these, a total of 262 patients were presented with a postoperative complication, which included infection, bleeding, wound infections, hematoma formation, and the urinary retention. Of course, these complications varied in severity and required appropriate management to ensure optimal recovery for these affected patients. Within 1 year of their initial emergency department visit, 31% of all the patients had 1 or more follow-up contacts with the urology unit related to their initial emergency department visit. This is a table showing the demographics of all the patients and how many of them were male, how many of them were self-referrals. And by self-referral, we often speak about either patients coming directly to the emergency department or coming through ambulance services. While in primary care, that's the general practitioners most often. How many of them had postoperative complications, and how many of the patients were catheterized, and then which type of catheters were used. the admissions, and as well as what was the number of contacts that patients had and how many of them had more than 4 contacts with the emergency department. So out of the total patient population, about 675 patients, or 28%, required admission to a ward. And as you can see in the table, so it's urinary and genital infections, which was the most common cause, followed by macroscopic hematuria, urolithiasis, and urocancer as the 4th common one. The median hospital length of stay was 4 days. About 48% of all patients underwent a radiological investigation, either directly at their first emergency department visit or within 4 weeks. And at the initial emergency department visit, acute radiological imaging, which in most cases is a computed tomography without contrast, was performed in 712 patients, and among them, 65 then underwent a CT scan. Among the positive findings, urolithiasis was the most common, followed by epidemiologitis, diagnosed mostly then with ultrasound. But notably, 466 examinations of these 712 showed no uroradiological pathological findings, with the main question being a stone or a concrement in the urinary system, as well as a total of 250 patients underwent surgical intervention. The most frequently performed procedure was endoluminal stone surgery conducted in 68 patients, followed by catheter adjustment in 47 patients. And then something that is well to note is that 999 patients received antibiotic treatment, which is quite a lot, but it also coincides with the different numbers done in the US and showed in their systematic reviews. What did we know? What did we find out more? Well, we found out that 20% were presenting with urological complaints had some form of urological catheter in place, which is quite a lot, but also quite common. The median age for these patients was also notably higher than the overall cohort, and the majority of them, 85%, were male. The primary complaints were blockage, dislodgement, or macroscopic hematuria. Among these patients, 43% required hospitalization with a median length of about 5 days, so more than the ones seeking for other type of disorders. And almost half of these patients received antibiotics, and more than half of them had at least one contact with our urological unit within the year of their visit to the emergency department. So what is interesting then in our study? Well, in contrast to other studies demonstrating seasonal variation in the incidence of urological emergencies, our findings shown no evidence of such seasonal variation. And a contributing factor to this could be that in Sweden, we do not get high temperatures such as in other countries. And with high temperatures, there's also a higher grade of dehydration, which increases the risk of patients being more prone to develop renal colic. Interestingly, though, the admission rate was higher among patients who sought care independently compared to those referred by a general practitioner in primary care. One of the causes of this could, of course, be that usually when a patient has an acute type of pain, as an renal colic, they tend to go to the emergency department directly instead of going through a primary healthcare center. But an interesting part within this is that the overall admission rate still remains relatively low, with only 1/5 of patients being admitted, compared to the national average in Sweden, which is approximately 1 in 3 emergency visits, which then resulted in hospital admission. So the relatively low admission rate, despite the high number of GP referrals, may indicate that the primary care providers might not always fully assess the severity of conditions before referring patients to the emergency department. This highlights areas where the primary care system could benefit from increased capacity to manage urological emergencies. And to address this, we could talk about maybe trainee programs to enhance primary care providers' ability to diagnose and manage such conditions. Additionally, equipping the primary healthcare facilities with essential diagnostic tools and allocating more resources to improve the access to primary care physicians to receive timely assessment with our consultants as well. The study reveals that almost half of our patients underwent acute imaging during their ED visits or within 4 weeks. This high proportion of normal imaging results observed in the study highlights the need for more judicious use of imaging. And over-reliance on imaging may lead to unnecessary radiation exposure, increased healthcare costs, and delays in clinical decision-making. Although this high rate of negative results might also suggest potential overuse, still 33 of our cases had urolithiasis, which can be a quite emergent and acute situation. But then we could see that clinical decision tools such as the stone score or the diagnostic algorithms have been validated to predict the likelihood of urolithiasis could aid us in these acute or emergency situations. And to mitigate these risks, it is crucial for us at least to establish evidence-based guidelines for when CT imaging is truly necessary. Then we were talking about our patients with urological catheters, which almost half of them required treatment at our department as well. And this population is predominantly elderly, making them more prone to complications, with nearly half of them requiring hospitalization. And in accordance with our results, the urinary catheterization is highly prevalent among patients admitted to urology departments, with up to 75% receiving a catheter during their hospital stay and around 20% already having one placed before admission. So this underscores the need for better preventive measures, such as improved catheter care protocols, timely assessment, and judicious use of antibiotics to prevent resistance, which is becoming an increasing problem, especially when it comes to urological diagnosis. And so we have 2 types of antibiotics that we like to use, and specifically ciprofloxacin, which we have noticed in the population demographics that they are developing bacteria that are becoming more resistant towards these antibiotics. So what are the strengths of this study? Well, it is the first Scandinavian investigation regarding the epidemiology of urological emergencies. It provides valuable insights into the urological acute care landscape and related factors within the population, offering a snapshot of data that can inform the public health planning and resource allocation. A study population of 2,433 patients, it provides a solid foundation for making further decisions regarding the development of acute care services. The limitations of the paper is it's a cross-sectional nature of the study. It cannot establish any causal relationships, as both exposure and outcomes are measured at the same time. The study may also be influenced by biases, including selection bias, that the participants included in the study may not be representative of the broader population, potentially skewing the results and limiting the generalizability of the findings, as well as the study was done in 2019, which was the year of pandemic, and there's a high probability that maybe some patients did not seek emergency treatment, believing that they could by drinking more fluids or using more home remedies to treat their urinary tract infections. So what is the conclusion then? Well, most patients self-referred to the emergency department, and many required admission, particularly for urinary tract infections. Acute imaging, mostly CT scan, was performed in a considerable number of cases, although many revealed no pathological findings. Interestingly enough, self-referred patients had a higher admission rate than those referred by a general practitioner, suggesting maybe potential gaps in the primary healthcare system, and enhancing the management of urological emergencies in primary care and establishing clear guidelines for acute radiological imaging could play a significant role in improving patient outcomes. And as a last picture, I would like to thank you, and as well as this was my AI version of how I would look like maybe if I was there with you during these days. I think that BHAAAS really provides a unique platform for me as a young doctor with Bosnian descent to both get connections with other colleagues, both in Bosnia, but also abroad. So thank you so much.